can look back
Not a
later on.
problem.
Okay. I would just give a short introduction, if that's okay with you.
Yes,
And then the floor is completely yours. I will try to moderate the chat if there are any questions from the students, if that's okay with you.
yes, indeed. My understanding is that we were just going to have a dialogue, question and answer. Is that what you were expecting?
I thought you were going to tell something about your book, Epidemics and Society, and to discuss that a little bit.
Okay, I can do that also if you prefer. Yes.
Yeah. Okay. And then we will have to see how many questions there will be and how interactive we can be with you. Is that okay?
Of course.
Okay. So nearly everyone is in, I guess. Let's see if yeah. So welcome to every one of you, and also very much welcome to Frank Snowden from Yale University. Very happy that he can be here for this session within our minor Global Health 2020. And I, as I told the students earlier, I was reading the book by Joe Barry, The Great Influenza, a couple of months ago, and in that book there are so many similarities about the Spanish flu pandemic and the current COVID-19 corona pandemic. And I told the students as well that it is very interesting to see measures taken by people and measures not taken by people, stupid measures, good measures, and that the same repeats itself 100 years later. And that also in the Spanish flu pandemic, an antimalarial quinine was used to treat influenza, while we are now using hydroxychloroquine to treat COVID-19. So if you look at that, then we didn't learn very much scientifically the last 100 years. Having read that book, I stumbled on your book, Epidemics and Society. And of course, your book deals not with influenza, but I think nearly with all the other pandemics that we've seen in the world, beginning with the plague and ending with of course, your updated introduction, COVID, but before that, HIV and Ebola. Now, I'm an infectious disease specialist. I started my medical school here in Rotterdam in 1981. And so in my third year of medical school, we heard about this new disease and about this possibly new virus, which ultimately would be HIV and HIV/AIDS. Later on, when I graduated and started my infectious disease training, of course, since then, so since 1995, I take care for HIV patients in the clinic. And I think, to me, at least personally and professionally, HIV is an example of many things a disease could do, and also what science can do to find cures or at least treatments for this disease, and how then the face of an epidemic, at least in the West, changes dramatically. Very often I show students as an introduction to what HIV is, and that it's more than a disease, and that stigma is also a very important part of the disease, and at least experiences patients have with that disease. Is a trailer of the band Played On, one of the older HIV movies, of course, and then also The Normal Heart, where stigma and at least politics and not working scientifically could hurt people and could hurt an epidemic, which you also describe in your book, Epidemics and Society. I loved reading your book because I think we can learn a lot from history, and history repeats itself. For me, it's very striking to see that measures taken during Ebola in 2014 were not that dissimilar from measures taken during the plague pandemics in the Middle Ages in the 14th century. So I guess that's also one of the reasons to invite you to share your experiences and your opinions on this, because I think we can learn a lot about history and learn from history to prepare better for future pandemics. And I think COVID-19 essentially makes clear that we didn't learn so much with all the pandemics we've seen so far in our modern age, but we can discuss that perhaps as well. So with that, and the other thing, so for the students, I came to know about Dr. Frank Snowden because of his book, and then I saw that the book was published by Yale University. So I asked Rich Skolnick if he could introduce me to Frank Snowden, and since then we have been communicating about Frank being part of our course, and very happy that you can join and share your thoughts on epidemics and society with us.
Thank you very much for your kind introduction, and I'm very happy to be with you. I would like to direct the conversation in ways that you would find interesting or useful. So I'll save most of our time, of course, for a dialogue rather than making this a lecture. But I thought I would begin with a few comments that may help to set the stage. And first, I'll begin with a number of personal comments, which is how the book came to exist. And I think that that's related to a concern of mine, as I discovered later, with the mental health aspect of COVID-19 and the way in which it's likely to be followed by a large-scale impact lasting for some time on mental health and well-being. Now, the reason I wrote this was, first, I had been dealing for 30 years before I started work on epidemics in society with epidemic diseases of malaria and Asiatic cholera. And I noticed in SARS was really decisive event in my life, it turned out, because I noticed that my students at Yale University found that there was nowhere in the curriculum, either in their science classes or in the medical faculty, where there was a discussion of epidemic disease and their history. That is to say, they studied them, of course, infectious diseases from a scientific point of view, but there was no attention to situate that in a historical context. And so I found that I was rather besieged, such was the anxiety of SARS in 2003, about what was the likely impact. Where was it likely to go? What was likely to be the end? Was this something that had been experienced in the past? There was tremendous anxiety. And so I thought that it was a sort of responsibility of mine to deal with this in a structured way. And so I began teaching a class on epidemics in society in 2003. This then emerged as a book in the end of 2019. And then I thought I would tell you a funny series of personal coincidences. The first was that it was published in October of 2019 with something of a somber prediction at the end of the book that this was Ebola was likely to be considered in retrospect a dress rehearsal for a much more serious pandemic undoubtedly a pulmonary pandemic that would be coming later. And to my astonishment, that began in, unfortunately, in December 2019. So I left then to do research in Italy on a different subject, and found myself, ironically, it was in Italy where I was located, not thinking I would be devoting myself to epidemic diseases again, but I ended up being in the epicenter of the disease in Italy, which was for a time, a number of months, the world's epicenter. And that was a very important moment for me. First, I suppose we could say, I contracted COVID-19 myself, and I was very fortunate to have a mild case, but perhaps the effect was to give me greater street credibility having done that. In addition, I began to realize that I upended my research and devoted myself, and have since, almost exclusively to researching COVID-19, particularly with review to its historical context, its origins. How should we define it as a disease? What is its likely impact to be on our society in terms of physical health and also mental health impacts? So that's what I've been doing. I noted a number of interesting things while living in Italy, and I contrast that with the United States. One is the very great importance of messaging during a pandemic, which is to say that the Italian messaging was done by the prime minister coming on the television and announcing the lockdown measures, explaining them in scientific terms and public health terms, and saying these are the only measures that we have to deal with this disease, social distancing and masking, and therefore it's the only method that we have to protect our nation, our community, our families, and ourselves. And this was the single message, and it was then taken up by newspapers that public health vans went through neighborhoods and proclaimed the same messages. There were wall posters, and everywhere it was the same. If one contrasts that with the United States, where you had instead the most striking opposite reaction of the dealing with the disease, which is to say, it was rather like, if one can imagine, an attempt to have a symphony orchestra without a director. That is, and the result was cacophony. That is to say, there was no single messaging. There were 50 states. Each had its own approach to the disease. They were contradictory, each with another, and so we had a totally fractured response. The result being, in Rome, the local newspaper said a miracle had happened, which was that in 3,000 years of the history of the city of Rome, this was the first time that Italians had ever been obedient. Whereas in the United States, you have the reaction instead that people have resisted masking, resisted social distancing, have had corona parties, and all the rest of it. And the result being that the United States has the worst possible record for dealing with the coronavirus. That is to say, we have not flattened the curve, and instead we're in the midst of an ongoing, we haven't had the second wave because we haven't gotten over the first wave as this moment. So I thought a first major lesson then had to do with the messaging. Then I wanted to turn to Professor Noven's, excuse my Dutch pronunciation, point in opening, which was to talk about the relationship between COVID-19 and the Spanish influenza of 1918 to 19. And I wanted to make 2 points. One, of complete agreement in terms of the public health measures. It's striking to look back to the 1918-19 pandemic and note that almost everything that we do today, admittedly, the clinical care has evolved since the start of the epidemic, but in terms of public health measures, they're largely the same while we're waiting for a vaccine or an effective therapy. Those that if someone were in a time machine, a physician from 1918, and were to come to visit us today, would say that it was very recognizable, the approach, even the protective personal equipment. And indeed, this goes back to public health adopted in the Renaissance. So there is this long-term trajectory of continuity of public health in that domain. On the other hand, I would differ just slightly because I would define the COVID-19 as the first pandemic of the era of globalization. And I would make a real distinction in terms of preparedness in the future from the influenza of 1918 and 19, which took place before the first transatlantic flight had occurred and was spread more by troop movements than by travel or tourism or other means. I would define the major factors in terms of globalization that launched. In other words, I think that infectious diseases are not random events, but rather they exploit pathways that societies create and that those microbes are able to exploit. And in terms of COVID-19 and globalization, it would seem to me that the relevant factors have to do first with our enormous overpopulation in a world approaching 8 billion people. And with that, a rapacious economic system that pays far little attention to the environment, to other species, and to biodiversity. Now, those are two major factors. Then come, I would say, the next major factor has been a rampant urbanization, so that we now have enormous conurbations and also mega cities of millions of people, and all of these are linked by rapid air transportation, with millions of people every year traveling by airplane from one major city to another in a matter of hours, so that what happens in Jakarta in the morning in terms of an infectious disease can be present in Rotterdam or New York City or Los Angeles in the evening. And so I think this is a very different world from that of 1918 to 19. And one can see, first of all, where this came from clearly has to do with our relationship with other species. And through such invasive actions as deforestation, palm oil production, invasion of wildlife habitat, extension of roads, these have altered the relationship that human beings have with the environment and with other species, and this has created the background for repeated spillover from other, that is, zoonoses, from animal infections, particularly bats, to human beings. And we are much exposed, and indeed, there's been a constant history. I would say that from a public health point of view, the age of globalization begins in 1997 with the avian flu. And I would say that because I believe that the pathways that the viruses have taken to affect human beings are those created by globalization, and that there's been a constant view among virologists since 1997 that a major pandemic of a pulmonary virus was in our future. This was seen with the predictions about SARS, MERS, Ebola, and so forth, that this was a major threat that our society as a global one is particularly imperiled by. Indeed, Anthony Fauci testified in 2005 to the United States Congress, and he made a very interesting observation. He said that it was rather like meteorological science, that if one were talking to someone who lived in the Caribbean, it would be possible to say to them that a hurricane was inevitable in their future, a major hurricane. One couldn't say the date or the strength of the wind, but it would be extraordinarily unwise not to prepare. He said that virologists can say exactly the same with regard to the outbreak of a pulmonary virus, an epidemic challenge on the scale of the Spanish influenza, or even possibly worse, Fauci said. One can't say the date or say what the mortality will be, but it was inevitable and we must prepare for it. Now, as a global world, we haven't prepared. And I think that that is part of the story of COVID-19 and one of the major lessons, despite I think the most poignant statement of the whole of the pandemic thus far has been President Trump's question, who could have known? My response to that was that everyone should have known, because there has been a constant history of a quarter of a century of virologists and epidemiologists predicting that an event of this kind would occur. Indeed, the World Health Organization in 1919 published a study by a very eminent commission examining preparedness, and it came to the very sobering conclusion conveyed by the title of the report, which was A World at Risk. And the point was that as a world, we were enormously vulnerable to a disease transmitted by air, by rapid air transport, by enormous links. Let me just illustrate Lombardy, which was the epicenter of the coronavirus. And this was not by chance. Lombardy is the most dense population in Italy and one of the most dense in Europe. It is also an area because ironically of the success of the Italian healthcare system, it has one of the oldest populations, indeed the longest longevity. It's the second in the world, and had a very large cohort of elderly people who are most vulnerable to a disease of this sort. And it was also linked, it has 2 international airports. It has direct flights, 6 flights a week directly from China. 35,000 Chinese people live in the city of Milan, that they have enormous economic exchange. They have built their economic, China and Italy have met at the highest level to coordinate investment and to have people back and forth, goods, services, fares, training between the 2 countries, an enormous investment. So Italy was enormously linked with China. It wasn't a distant place in the early months of 2019. It was therefore, I would say that globalization is fundamental to understanding this pandemic, and it also teaches us what we can do in order to be prepared for the next. Because I think one of the lessons of this coronavirus is this is unlikely, almost certainly will not be the last major pandemic challenge. And so what lessons can be drawn for this, for the future? And I think we need, as a world, to do something about the relationship with the environment and with other species and deforestation. It's also true, part of globalization has been in climate change, and that's enormously important in the coronavirus challenge. And we can see this in a number of ways, one of which is the importance that's now being understood of particulate matter pollution and its effect in making people vulnerable to pre-existing causes of lung disease and asthma and a whole series of factors that predispose people to this sort of disease. Also, one sees the lack of healthcare readiness, in that our healthcare systems were not prepared to cope with surge in a medicine for profit environment. There has been enormous cutting in the years before 2020 of the healthcare ministries all around the world, as they have followed a neoliberal economic policy, and many countries have millions of people who are outside the healthcare system, which means that if they don't have access to care, that they don't have, the healthcare system has no possibility of knowing where the disease is and how it's moving through the population. And so a healthcare system in which universal coverage is provided is part of our survival apparatus as a species. And Dr. Tedros, the Director General of the World Health Organization, has been saying around consistently ever since the beginning of the pandemic that a major requirement for preparedness is having universal access for every citizen on the planet. And this is something that we certainly did not do before the onset of COVID-19. So I believe then that environmental damage, the climate change, relationship with other species, lack of biodiversity, our enormous overpopulation, our vulnerability to diseases transmitted by droplet and aerosol make us very vulnerable to the next epidemic challenge, and that this needs to be one of the great lessons that we draw from this experience of COVID-19. So those were things that immediately came to mind in talking and introducing our discussion, but I could go on at enormous length, and I don't wish to do that. It would be better if we had a dialogue, as we've both been anticipating. And so I'm very happy to now lapse into a moment of silence and to have any questions that you would, or aspects that you would like to discuss. And I'd be more interested in hearing what you think would be important and interesting to talk about. So thank you for your attention, and I'm very happy to be with you this afternoon.
Okay, thank you very much for this elaborate discussion or about your personal experience then as well in with COVID-19. So there's one question from Nadine, one of the students. Could you elaborate on how the environment, as in lack of biodiversity, links to a greater vulnerability to airborne diseases?
Yes, absolutely. If we think about the way in which it's not by chance that this disease began in China, China has a number of features involved. It's nothing to do, let me reassure you immediately, I'm not taking a Trumpian position that this is a Chinese virus in any way. Has nothing to do with Chinese DNA. It has only to do with physical circumstances of Chinese topography, demography, and so on that are important. And one of those features is an enormous population in Southeast Asia of bats, and bats that carry I believe the EcoHealth Alliance has been doing, a nonprofit organization committed to exploring the relationship between environmentalism and public health, has been doing enormous research on the viruses that these bats, certain species of bats, transmit. And I've discovered that there are something like thousands and thousands of viruses that are capable of being transmitted to human beings, and have noted that the density of the population and the various cultural factors that have led to increasing invasion of bat habitat, that, for example, they discovered that if you go into caves where thousands of species, different species of bats, thousands and thousands of them are roosting in a cave, and they seem to be interspecies roosting, so that viruses are exchanged between one species of bat and another, and people, they find in the caves signs of lots of people have invaded the caves and been part of breathing in the particulate matter, that is to say, from the bats, and that they've also conducted numerous studies to test people in areas near these densely bat inhabited places, and discovered that there had been a long series of exchanges, that is to say, what happened in Wuhan was based on a large number of pre-existing exchanges of viruses crossing the species barrier between bats and human beings. That is to say, as biodiversity is decreased, and as the bats are driven also from forest canopies into areas more adjacent to human beings, as human beings also through hunting and other activities actively invade the habitat that bats are in China, there has been this process of spillover that a number of scholars and scientists have been investigating, and that's one of the leading problems that we face. And so a lot of thought about public health is now directed, since that is true, that leads to consequences in dealing with this danger, and therefore the need for surveillance and for testing in these areas to have an early warning of outbreaks and clusters of cases of viruses transmitted across the species barrier. So this is a major part of preparedness for the future. And so the ecological impact on biodiversity and our relationship with animal species, in particular bats, is tremendously important. And it's not by chance then also that globalization is very important, because this took place in an immensely densely populated part of China. And so, having crossed the species barrier, it was fairly easy for a disease transmitted through the air by aerosols and droplets to spread in clusters and that is community transmission once it had reached an urban environment. Possibly there's been a lot of discussion of wet markets and their role and that sort of issue, and one can talk about that, but I think that it's becoming increasingly clear that perhaps the way of conceptualizing it is not of a single spillover event, but of an ongoing process of spillovers into the human population, and that this time it began to spread in clusters within the community, and then to spread through China and then throughout the world. And indeed, because of China's link, for example, with Lombardy that we were talking about before in Italy, the ease of transmission, and this became and erupted into a pandemic in that way. So it does begin with the viral spillover from animal species to human beings. And this is not the first example of that. If you'll remember, Ebola also began with the spillover of a virus from bats again, when their habitat had been invaded by palm oil companies in particular, and there was rampant deforestation, so that bats were roosting in they had been driven from the forest canopy to live closer to human habitation. And the first index case, as you remember, of Ebola was a child who was playing in a tree, and the tree was hollow and contained hundreds and hundreds of bats. That was the index case of Ebola, and all of the cases in West Africa, genomic research has indicated descended from this one case. Once again, an example of spillover and the impact of biodiversity. One can see this also on the same mechanisms at work in MERS, going all the way back to avian flu. And SARS was a very similar story. And indeed, there, the implication of a wet market and the transmission from bats to other animal species in the wet market and then to human beings has been demonstrated in the case of SARS. So we've had this series of pandemic, if we like, dress rehearsals. Those diseases, fortunately, were not so readily transmissible and didn't have asymptomatic transmission. And so they were not major catastrophes in the way that COVID-19 has been. But this is the kind of transmission, the kind of disease that we as a species are tremendously vulnerable to, and our relationship with the environment and with other species, with biodiversity, is an important part of why we're vulnerable and where we can expect more spillover events to occur.
Okay, thank you. I have one follow-up question on that. So would you say that for HIV, where there's also spillover from monkey viruses to human beings, has been caused by deforestation or more close interactions? Or would you say that was more like a random accident happening by people moving into the forest looking for bushmeat and those kind of things? So in that sense, is that different than what we've seen for SARS and now for COVID-19 and for Ebola?
Mm-hmm. I think I would say that there is a direct relationship there, and that even at that point, there was, if one reads the journalists' accounts at the time, that there was a sense that this was somehow an event emerging from the darkest jungles of Africa, this sort of journalistic rhetoric. In fact, it had a lot to do with the involvement of people in natural habitat, with population growth, and the way in which people did, as you were saying, involved in bushmeat, but that is also not something that is exotic. This is a part, we call it that bushmeat has been associated with Africa and China, but simply game is a very common term that we all know and is part of our own culture as well. And one can see indeed that that's implicated in the spread of bubonic plague in the south of the west of the United States. At this very moment, there's a constant trickle of cases as a result of hunters invading areas where there is a bubonic plague reservoir. And I would say that, and they hunt and therefore they become vulnerable to the fleas and the transmission of the bacterium that causes the plague. And that's very much the story also, it seems, of how HIV/AIDS spilled over to the human population. So yes, I wouldn't regard this as a random or chance event. It's also part of the story of the human relationship with the environment and other species. That seems to me a very important part of our biological history.
Okay, so you mentioned bubonic plague now. There's a question from Leonard Heuvelman who says, apart from the corona epidemic, so he wants to switch to something else. Could you tell something about the Black Death? And it may have been the most deadly disease. What factors contributed to this in the Middle Ages?
It's very interesting to think about bubonic plague now, because this is a period where the history of bubonic plague, if one can imagine it all these centuries later, is now being reconceptualized because so much more is being developed by interdisciplinary research. That is to say, not any single discipline, but a pooling of resources among geneticists, archaeologists, historians, literature specialists, and what they have discovered in the last 5 years or so is that the bubonic plague was transmitted undoubtedly not just through trade, but through the Mongol expansion of the Mongol Empire from a reservoir in Central Asia, and therefore warfare was critical in the transmission of bubonic plague. That's an important feature. That's undoubtedly how it reached the Levant and the Eastern Mediterranean. And so the experience of warfare was crucial in bubonic plague. Then it was transmitted to Western Europe by trade and the trade routes. So those were critical sources of vulnerability. It was also true, however, and this is the history had been rather Eurocentric. It turns out that, in fact, bubonic plague was also ravaged West Africa and East Africa, that the Saharan Desert was a highway rather than an impenetrable boundary, and that archaeologists have discovered the abandonment of numerous sites in West and Eastern Africa precisely at the plague period, and mass graves, as one might also find in European centers. And so the historiography of the plague is being rewritten as we speak to be a much more transnational global experience than was ever thought, warfare playing a much more important role. And then there's been a lot of attention to preconditions, as people talk about with any major pandemic disease, and to the economic conditions that prevailed in Europe before, on the eve of the invasion of the plague. And that is to say that there had been a period of climate change, again, something that we are familiar with as an important and relevant factor, that led to a whole series of failed crops, and therefore to famine conditions and malnutrition, in the middle of the 14th century. And it was this that formed the background to the enormous vulnerability of the population to plague, years of poverty, hunger, and poorly nourished population is a relevant factor as well. So the bubonic plague, we now also know that there had been a number of plague deniers who thought that what took place in Europe wasn't the bubonic plague, but perhaps was anthrax or some other disease, their argument being that bubonic plague, by the spread of the nexus of rat, flea, bacterium, human beings, that would not move in sufficient rapidity to explain the passage. The plague landed in Messina, Sicily in 1347 aboard a ship from the Levant, and then the disease moved across Europe very rapidly. That, however, it also moved to Northern Europe and broke out. There were plague epidemics in Moscow during the winter months when fleas are inactive. Well, the point being that people neglected to take into account that bubonic plague can be transmitted in more than one way. Certain strains of the bacterium lend themselves to transmission, the pneumonic plague spread through the air by droplets. And that would be ideally suited to be transmitted rapidly and even in a Moscow winter when people are gathered indoors. The disease could spread quite handily and undoubtedly did. So those are a number of new directions that are now becoming increasingly clear. And another new direction that's rather worrisome with recent events in mind, and that is the extraordinary degree of political and social tension and scapegoating in the time of bubonic plague, that this was one of the times when there was an enormous upsurge of anti-Semitism that swept the Rhineland, France, and large parts of Europe, indeed the Low Countries as well. And this was a precursor of the 20th century, that is to say, destruction of the European Jewish population, or a large part of it, occurred during the early years of the Black Death. And it didn't arise simply it was encouraged, it arose, this violence against the Jewish population occurred both from below in spontaneous terror, fear, and xenophobia, but it was also abetted by magistrates, by political authorities as well. And that's another part of the story of the bubonic plague. Dr. Tedros said that with regard to COVID-19, that there was a plague of misinformation and xenophobia that was just as dangerous as the physical disease, and that certainly was the case in the time of the bubonic plague. I hope I'm answering the question that you were asking. If not, please tell me and we can talk more about bubonic plague and its impact, if you like. But I did think it was crucial to bring out the xenophobia and stigma as major factors of pandemic disease, and that are drivers of the pandemic. They're drivers because they misdirect resources not to deal with the actual causes, but with pseudo-invented causes.
Okay, thank you very much for that. Let's see what questions are then. So there's one question again about the Black Death, so we will stick to that for 1 minute and then go back to COVID-19. So there's one question if the Black Death changed the genetic makeup of modern European population.
It does not. That's something that is still to be worked out. One doesn't know yet because there hasn't been enough genomic research on the relationship of the Black Death to human genome. We know that it sculpted a European art, politics, public health, but it's not known that this was had a major impact on our genetic makeup. So I don't think one can sustain that argument. Anything that one said would be speculation rather than something based on knowledge. What we do know from genomic research, however, is that the plague deniers were undoubtedly wrong because there has been quite a bit of excavation of burial sites of plague victims, and they have extracted dental pulp and isolated DNA from Yersinia pestis, the bacterium that causes the bubonic plague. And so it's quite clear now that the bubonic plague was not caused by anthrax or another morbidity, that it was definitively a disease caused by Yersinia pestis, and genomic research has been critical in confirming that and establishing its epidemiology.
Okay, so there's another question which relates more how epidemics end. One question is, how did the Black Death and Spanish flu end, and what lessons can we learn from centuries ago?
Right. How did the Black Death end? And I think there are two answers to that. One is to be sure that we remember that, in fact, the Black Death hasn't completely ended, that over 2,000 people around the world die of Yersinia pestis every year. There's a trickle of about 20 deaths from Black Death indeed in the United States every year. So it is a disease that persists in animal reservoirs. It was also a disease that was actually weaponized during the Second World War. And the Japanese army in China had a unit that was dedicated to biological warfare, and they did indeed launch some devastating epidemics of bubonic plague in China, and in northern China that they occupied. And the end of that story is not edifying because after the war, instead of having those researchers being tried for war crimes, they were instead hired by both the USSR and the United States for their biological research laboratories. And so we see that bubonic plague had that legacy as well for the modern day. So, but then and there was another pandemic, a third after the Black Death, that is to say, around the 1890s, there was another massive pandemic of the Black Death that caused some 30 million fatalities. Its epicenter was the Indian subcontinent, and it killed some 30 million people in India in particular. So there was that other pandemic. But I suppose the question then is, how did the Black Death end in Western Europe? What factors account for it? And there's a great deal of debate, and I don't want to say that there is, it's still an open question, but people doing research on that topic point to the following factors. One thought is that there may have been this is speculation, an evolution in the flea population. and that this may have been a factor. Another factor is another very humble one, but we talked about the rat-flea nexus. Well, there are two species of rat that are very relevant. One is Rattus rattus, which is the black rat, which was mostly responsible for the transmission of the bacterium during the centuries of the Black Death. And it was a rat that, in fact, was very sociable and lived very close to human beings. So much so it was considered in the third pandemic. We know that some people in India regarded it as almost a domestic animal. And when there were attempts to trap rats, they actually freed them because they thought the black rat was cute and almost domesticated. Well, this rat was replaced by Rattus norvegicus, the brown rat, which is much larger and much more aggressive and much more retiring, does not like being near to people. It's the rat that we all know and love today. And this rat, because of its shy, retiring distance that it lived from people, is not as efficient a vector as Rattus rattus had been. So then there are hygienic features. Having concrete foundations for buildings is quite important in keeping rats at a distance, unlike, let us say, dirt floor for domestic environment. Sanitary measures have been quite important. Also, there may have been climatic factors, as I was saying, and then public health measures, the human response that was organized beginning in the Italian city-states, Florence and Genoa, and then transmitted throughout Europe, of instituting measures of that we know today, the quarantines, sanitary cordons, plague hospitals, isolation. We would call these features social distancing, and indeed, I could say, and protective equipment. All of these were devised during the plague centuries, and it's certainly the case that probably, and with that, the emergence of the early modern state. Because if you're going, let's say you're going to have a sanitary cordon and isolation enforced by magistrates, you're going to have a board of health to enforce them. They need to have legal and judicial powers. They need to have taxation, record keeping, and all the rest of it. So part of the reaction, human response to the bubonic plague was to create centralized authorities that practice public health. And therefore, I would say another feature in the conquering of bubonic plague was the emergence of the early modern state power and public health mechanisms, and that the state not as a tyranny, but the state simply conceived as possessing what were called at the time police powers to protect public health. And the idea that public health is the supreme law. These were very important in the fading away of the great second pandemic of bubonic plague. But it's always something of a mystery why a plague pandemic fades away. And Robert Koch himself, who discovered the Vibrio cholerae, among other discoveries, said that the reason that cholera disappeared as a pandemics was something that was one of the great cholera mysteries. And I think we always have to be a little careful in being certain about knowing why a particular plague or pandemic comes to an end. And it's usually multifactorial. And I think that was certainly the case in dealing with the feature of the conquest of bubonic plague.
Okay, there was a follow-up. So there's an echo now here. Not sure if you heard it as well, but there was a follow-up question. So what measures did it take to end the Spanish flu then? Was that different
yes,
from
the Spanish flu.
place? Because we knew a lot, there were modern states, etc. So
Yes, indeed. It was clearly the case that the public health measures adopted to deal with the Spanish influenza were very important and were also demonstrated their efficacy. A way of telling that, the case that I know best in terms of public health is that of the United States. And if you compare just for a moment two cities, I would contrast their experience. One is the city of Philadelphia, where when in 1918, before the flu was already ravaging parts of Europe and parts of the United States, Philadelphia decided that it would be okay to have not practice social distancing, but rather to have a major patriotic parade called the Liberty Day Parade to welcome home the troops in November 1918. And so you had this tremendous parade. Hundreds of thousands of Philadelphians lined the streets, shoulder to shoulder, vying to see the soldiers and Boy Scouts marching and the bands and all the rest of it. And it was almost immediately after that that there was this tremendous upsurge of the influenza in the city of Philadelphia, and that it became the city in the United States that was most ravaged by the Spanish influenza. You can contrast that with the city. Why did they do that? Part was patriotism. It was also, this may amuse you, it was also because of a major scandal, and that was that the mayor of Philadelphia was, during this outbreak, was arrested for murder. And therefore, there was no municipal authority in place in Philadelphia. That's another feature. San Francisco, on the other hand, was a city that took very careful and decisive measures about social distancing and masking. It closed schools, it banned church services, assemblies of every kind. They call spitting in public was made a municipal offense for which you could be arrested. Also, for open-faced sneezing was also a legal offense at the time. San Francisco had the best record in the United States in dealing with the Spanish influenza, and is an illustration of the efficacy of the public health measures. So I would say that those were very important. Another feature, though, is that the Spanish influenza probably was so, its morbidity was so extensive that as it passed through a community, probably by the end of the third wave, the people who were most vulnerable to the disease had already been afflicted. So in a sense, it was like a fire that burns out because it has consumed the combustible material. That is not true of every pandemic, but it may well have been a feature in the ebbing away of the Spanish influenza. So public health, the course of the disease, its extraordinary morbidity, but also the fact that it provides a robust immunity among those who survive it. I think those were all features in the ebbing of the Spanish influenza, and I would be reluctant to look to a single factor and say, this is it.
okay, now you discussed differences between two cities during the Spanish influenza. There's a question about the current COVID-19 pandemic and fragmentation in US society. And I guess different responses at different levels in different states. But there's also a question about, oh, now I have to go back again because it scrolls down. Anti-mask movements, which are, I guess, and if that happened, if that plays a role, and if those kind of things happened as well during earlier epidemics and pandemics.
Right. First, with regard to fragmented public health in the United States, I think that we're living through, at this very moment, the evidence of that, the impact of having not having a public health system, but in fact, it becomes so absurd, awful that it's not just one state with regard to another, but municipalities within a state have completely different policies. I mean, I think that you're familiar from this with regard to the border between Belgium and the Netherlands during the COVID-19 and the different policies applied on either side of the border. The same thing is happening not just between county and county throughout the United States, that the policies that are adopted in one are very different from another. Now, it is the case that the New York State, for example, and a number of the New England states adopted very severe lockdowns and did something along the lines of what a number of European Union countries have done, which was to reopen only after the morbidity through testing had been demonstrated to be very low. And that we could see in what's happening today in the New England states, Connecticut, Massachusetts, but also in New York State, which have very low morbidities at the moment and very low populations of COVID patients in their emergency rooms and ICUs. So that's been a success story, but this is not the case in those states that did not practice. So it's the Philadelphia, San Francisco Spanish influenza story being retold. And we see that Texas and Florida, for example, and some of the states in the Midwest are being this huge upsurge of the epidemic, and they did not adopt the public health measures that we know to be our only defense, at least at the moment. And so, yes, that's a very important and serious issue, and we're seeing it played out in the United States at this very moment that we're talking. So that is critical. And then you were talking about, I believe, xenophobia
and anti-mask movement. So not wanting to comply with measures like masking or face masks, wearing face masks, those kind of things.
Absolutely. Okay. The United States has been, and here I don't want, there have been attempts to say this is about the individualism of US culture. That may play a role. There is also a great deal of anti-scientific skepticism in the United States, which has been fed from the top. I mean, the White House in the United States has argued that this is no worse at various times. It's no worse than the flu. That this is actually not COVID-19. It's the Chinese virus. That the response that would be effective would be a nationalistic one of closing borders. We've also had the president saying that masks are not effective, and governors of a number of states. This is also an administration that doesn't believe in climate science. And so there's been a great deal of anti-science that has been preached in the United States by political leadership. And with this, we also see the healthcare is so fragmented that public health has been compromised by the fact that even a renowned institution like the CDC has been politicized and is now giving contradictory messages. And so it's not by chance that the public is enormously confused about what is responsible, what should be done, and what shouldn't be done. And we do see this enormous backlash of people who are defiant with regard to the wearing of masks and regard it as a sign of lack of masculinity for some reason, that they regard it also as an imposition of authoritarianism on telling people how they should behave. And I think that is another very important feature in the upsurge, the unwillingness, and indeed, even if a vaccine that's safe and efficacious is introduced, it's now the case that polls suggest that 30 to 40% of Americans would refuse to be vaccinated against COVID-19, such as the distrust of science and such as the strength of anti-vaccinationist sentiment in the population. So this aspect of anti-science and anti-mask wearing, anti-vaccine sentiment is a very dangerous one for United States public health. And we're living with the consequences of that. After all, the United States has done worse than any other country in the industrial world with regard to COVID-19. And I think that this aspect of a fractured medical system and a culture of rejection of scientific authority have played major roles in that.
Yeah. So you mentioned vaccination now. There's a question also about vaccine development for COVID-19. And you mentioned the number of people who will not take corona vaccine when available. Richard Skolnick last week in his masterclass said that the scientific world in the United States also is afraid that Trump will push, or the Trump government will push for FDA approval of a vaccine 1 or 2 weeks before election day in November as a campaign instrument. But Richard also said that if this vaccine then would not prove to be safe, that would enormously hurt all vaccine programs in the United States, but also probably in the rest of the world. And of course, today we saw messages from the Oxford vaccine that the study has been stopped because of side effects, at least in one volunteer participant. So what would your idea be about it? And then, of course, it refers a little bit, I guess, to the Qatar incident a long time ago. I'm not sure if the students know about the Qatar incident, but you can explain that better than I can, I guess.
Yes, the Qatar incident had to do with polio vaccine. And there was a laboratory in California. I'm a little bit hazy at the moment, but if the best of my, I'm having a senior moment, shall we say, but to the best of my recollection, the laboratory is located in California, and in the rush to push out to the public a vaccine to meet the enormous demand for an anti-polio vaccine, a couple of the laboratories of the Qatar laboratories compromised on safety measures. They took shortcuts in producing the vaccine, and it had very serious side effects as a result. And this was one of the reasons that there was an upsurge in anti-vaccinationist sentiment in the United States. So to some extent, one could say that we're living today with some of the legacy of the unfortunate Qatar incident. And I agree with Richard that there is enormous pressure on the Federal Drug Administration to license a vaccine in a hurry for political reasons to facilitate the president saying that he's taken effective and decisive action, and here is the vaccine as a present to the nation. Now, I think that the problem is that it's going to have a lot of negative repercussions either way. Let's leave aside the politics in a way of it and say, should such a rushed vaccine lead to adverse consequences? Of course, that will strengthen anti-vaccinationist feeling, but I think if it's rushed out anyway, it's likely to create enormous distrust among people who fear that it's such a blatant political gesture and that the vaccine hasn't been properly tested and scientifically validated. And I think a lot of people will be, perhaps for reasons that one can be very sympathetic with, very skeptical about such a vaccine. So I believe that it may even be that the anti-vaccinationism may be stimulated by the political process, which is so blatantly transparent, of producing a vaccine rapidly for reasons for which public health is only secondary. So yes, I'm very worried about that.
Okay. There's another question. Is fighting a pandemic like COVID in our time easier or harder, you feel, than a pandemic in the past?
Oh, that's an interesting and difficult question to answer. I think it's a difficult disease to deal with. When the Spanish influenza broke out in the United States, the Surgeon General said that he felt very humble because although it was the 20th century, he felt he knew no more about the Spanish influenza than Florentine physicians had known with regard to the Black Death. Now, when COVID-19 broke out, I think we can say something relatively similar with regard to what was known about COVID-19. It was a new, recently emergent disease about which much more, even today, is not known about its pathophysiology, its sequelae, its vulnerability to seasonality. There are so many questions of whether it's more spread by aerosol or droplets. There's so many debates about it, and we had neither a reliable treatment or treatment protocols, nor a vaccine to prevent it. So fighting it has been enormously difficult, and we can see that the disease is really well adapted to the conduits that I was trying to stress at the beginning. I forgot to say the conduits of poverty and inequality that in the society, and that is true both internationally and with regard to individual countries, that the disease is not a disease. I know that it afflicted Tom Hanks and the Prince of Monaco and Boris Johnson. So it can afflict, and skiers in Austria. But nonetheless, it's not above all a disease of the affluent and disease of universality. It is above all a disease of disadvantage and of poor people. And it's been spread enormously. Nearly 40 and 50% of those, the mortality from COVID-19 in industrial countries has been among elderly populations of care homes. And so this is, which is an extraordinary percentage, 40, 50%. So it's really a disease that spreads on conduits of disadvantage, lack of access to care, and congregate living. So they're very particular. It spreads in clusters, unlike a number. So its epidemiology was also unanticipated, and the role of super spreading events has been enormously important. So the world has had to learn about the epidemiology as well as the pathology of the disease, and getting on top of it has been very problematic. And there are many virologists and epidemiologists who think that this is a disease that may in fact become an endemic disease, for which, with which, not to say that this is the end of the world, and no one is taking an apocalyptic position with regard to it, but rather a disease that we may need to live with over the long term and adjust the way we live, rather than talking about bringing it to an end. I myself am a little worried with the idea of bringing it to an end, because we don't yet know whether that's in fact what will happen. We may have to learn to live with the disease, which is to say, to contain and mitigate it. Those seem to control rather than eradication seems to me a reasonable position until we have, in fact, the tools to, if it is possible. We don't know, even if when we do have a vaccine, whether it will be robust and provide a lifelong, lasting, robust immunity or not. That's an unanswered question, and we shouldn't make assumptions about what a vaccine will actually provide us with. That's all to be seen. I think the safe position at the moment is to assume that we need to reorganize our ways of living and interacting in order to deal with COVID-19.
Okay, so to follow up with that, there's a question. So how will COVID-19 change the world, looking at global health and cooperation between countries? Do you think countries will work more closely together to try to prevent or combat future outbreaks and take bigger steps in order to achieve universal access to health? Or will they forget and then, like we forgot about SARS, MERS, and other outbreaks?
I suppose here it's a question. There's a famous philosophical comment that perhaps the best stance to adopt with these difficult problems is one of pessimism of the intellect, but optimism of the will. That is to say, I feel there are many grounds for pessimism, but I think we also, pandemics also have a silver lining, in a sense, of offering enormous opportunities for change in positive directions, for the strengthening of public health and scientific knowledge. And I think COVID-19 does present such opportunities. And one can see that these aren't simply things that I'm imagining. It's rather that cities, Milan, for example, is trying to devise ways that to assume that COVID-19 is going to be with us for many years at a minimum, and therefore businesses will have to practice more distant approaches. The public transportation system will have to play a much smaller role, so there are no longer crowded subway cars, that the sidewalks have to be much less space for automobiles and much more space for pedestrians so that they can practice distancing as they go about their business and shop. So urban life is being reconfigured in parts of northern Italy as we're speaking at this moment. Those are examples of ways that life can be reconfigured. It's also true that this is happening with regard to educational institutions, and many institutions are practicing distance education. to a much, so a lot of ingenuity and technology are being brought to bear on this problem. So I think there are lots of, one imagines with regard to international cooperation, my view would be that in the short term, I'm rather pessimistic. That forces of nationalism have led to fragmentation within the European Union. And the United States has set a terrible example with regard to its attacks on the World Health Organization. I think that nationalism, microbes don't respect national barriers. So that is not a winning strategy. But it seems to me that one of the features that gives me optimism in the long term is that I believe that those non-scientific, politically motivated, nationalist and divisive responses will prove to be failures, and that therefore we will be driven, not because we're good necessarily, but because we see the consequences and the results. And I think this is also the case with regard to health system failures. And countries like the United States, I think one of the lessons of this is the catastrophe that results if you have a fragmented health system and you don't have universal care. I think the American health system, not in the immediate future, but in the intermediate and long term, will be transformed as a result of this. And hopefully we don't have to also have later examples. Hopefully we can learn this more rapidly than that and be prepared for the next challenge. I also think around the world that the model, which has become the American model of for-profit care housing for elderly populations, that has been demonstrated comprehensively in almost every industrial country, with a couple of exceptions. Japan is a shining example where the nursing homes have not experienced epidemics of COVID-19, but Italy, Spain, Sweden, the United States, these all have, Australia, terrible records for the United Kingdom for the death and morbidity of elderly populations in nursing homes. And so I believe that care for the elderly as a system is going to have to be financed and conceptualized and implemented and regulated in entirely new ways. That seems to be something that's going to need to change, and rather rapidly, because it's been a total fiasco and demonstrably so in this pandemic.
I guess the same for the Netherlands. Especially if you, I know for Rotterdam, that if you look at morbidity and mortality in nursing homes in the city and around Rotterdam as well, which is really a failure of our system as well, I guess. But then perhaps also again some kind of an unexpected characteristic of this epidemic as well. But okay. Let's see. There was. Oh yeah. So there are several questions which relate more to preparedness and how we as a world or global health world should prepare better to prevent these kind of things, or at least to mitigate if things happen as best as possible. There's a question about vaccine legislation around taking a vaccine. And I guess that has to do with reports today in our newspapers, where of course, if you work in a healthcare setting, if you work in a hospital as a doctor or a nurse, you would like to have all nurses and doctors take vaccinations and other people caring for patients as well, to prevent corona from spreading to patients being hospitalized. Now in our setting, that is not, you cannot make it compulsory. So there's no way of having demand vaccinations from nurses and doctors and other healthcare workers. You can say that they are not allowed at certain departments like the ICU to take care for patients. So I guess these are two questions. There's one question from Niels. Could we have a small break? So my question to you really would be, should we do these two questions and then wrap up, or should we have a short break and then answer these two questions?
Well, why don't we deal with the questions and then
Okay.
have a short break? That seems like a sensible idea. And with regard to preparedness, I wanted to add a slight, you mentioned, you were talking about the nursing homes, and I just wanted, I've been thinking a lot about them because of the extraordinary mortality. They seem to be a crucial site of this pandemic. And one that wasn't known exactly in advance. On the other hand, what's very striking is that, and one wants to understand why we are like this as a society, why are we so unwilling to prepare, because just as on the general level, I was talking about the warnings from virologists and epidemiologists about the likelihood of a pandemic and what did the world do, but it cut resources from healthcare systems, from scientific research all around the world. This was a terrible feature, and the European Union also was not prepared and didn't react in a unified way or distribute resources across the borders very much. There was a little bit of that, but essentially not. That's what didn't happen. And the United States was a disaster in this regard. But it does seem to me that the nursing home sector reinforces one's anxieties because what's so striking in the three cases I've been looking at, which were the United States, the United Kingdom, and Australia, which is that inspectors for years had been looking at nursing homes and saying in those three countries that they were very vulnerable to infectious diseases, that the staff were not equipped, that staff were moving from one nursing home to another, that they weren't trained, that they were the lowest paid workers in large measure, earning a minimum wage, and their morale was low, and that to maintain profitability, they were having the ratio of nursing aides to the population of elderly people was being increased year by year. So instead of the situation getting worse, it was better, it was getting worse. And as the population became older, so the sentiment among politicians was resentment towards the elderly population because that led to increased taxes to fund the nursing homes. And so they took to the course instead of cutting the funding. So there is, that gives one grounds for pessimism in a sense, but I prefer to think that the world will rethink the model of elder care in the wake of this pandemic, and that something new and different will have to emerge on that front. So preparedness is a major feature of this pandemic, and our lack of it is one of the reasons that it has ravaged the world to such an extraordinary extent. And we are not by any means, we're not anywhere near the end. Just look at not only the United States, but India and Brazil. And then think also of the threat of resurgence in Spain and other places. So I think we're in a very precarious moment. And so it is a time to think also about how we make our world safer to deal with the coronavirus that we're still facing, and then with regard to the future, because it's very difficult to believe, based on past experience and the warnings of leading scientists, that this is the last challenge that we're going to face as a global society. So that would be my sense of preparedness. And I've forgotten, I'm sorry, that if there was a second question. I just remembered the preparedness one. I'm sorry.
I'm not sure what the other question was again. Now, so we have a professor of virology, Marjan Koopmans, here at the Erasmus Medical Center. So our virology department was one of the co-discoverers of SARS as the cause of the virus causing SARS, and is also very much involved in MERS research as well. Vaccine development for dromedary camels to try to prevent the spread of MERS. She said that we were not prepared, and obviously we were not. And that one of the reasons was that with the Mexican flu, so to say, a long time ago, there was all kinds of preparedness measures taken, but that because it took a while before something else happened, and of course 2003 SARS, but that was contained rather quickly. Others being more focused outbreaks. That because of, and you said it I think already a little bit, that because of we or governments forget about the urge of being prepared, because it's been some time, some governments ago, that we have had a pandemic, that literally these preparedness items are more like books or written reports in a desk, and no one cares about them. And at least focus is distracted because there are other urgent things to take care of, and that also then money is very quickly moved from public health into other areas of importance. So is that something you think would happen again? If it's going to take some time before another epidemic arises, or would you think that with Mexican flu, SARS, MERS, Ebola, COVID-19 now in such a short period of time, really, this is really a wake-up call, and that we will be prepared for the next pandemic?
Yes, it's difficult for a historian to predict the future. But on the other hand, I don't want, it's such an important question, I don't wish to, to avoid it. And I think I would say that there are great grounds for historical pessimism, and that we've had many wake-up calls, and the drama has been that we failed to answer them. I'm hoping that this time will be different. We have the opportunity to be different. And I hope that, in a sense, occasions such as this and many others around the world, and journalism and so on, keeping this issue alive, and what we need to learn so that this doesn't happen again, I think is vital part. And this is a choice that we have. Isn't one of the features that makes pandemics of enormous importance and interest that they confront us with ourselves. And that is to say, they reflect who we are as a society, and we have both our dark sides and our better angels. And let us hope that this time we can learn, and there are precedents from that. We do see that the Florentines didn't simply give up with regard to the Black Death, but developed the discipline of public health, the field of public health as a discipline. And let's hope that that will be a similar result. I don't mean mortality. I mean simply wisdom of making use of this terrible experience to resolve that our politicians need to be accountable to science and to the public, and the pressure to make sure that this doesn't happen again by taking measures of preparedness, and preparedness in a united, recognizing that we're all in this together, and it does take an international effort, that the World Health Organization is in fact, although it needs, I'm not trying to say that it was in any way perfect during this pandemic, but it's placed in an impossible position. It doesn't have the resources and the funding and the political support to do the job that it was set up to do. And so we need a strengthened and reformed World Health Organization as part of our survival kit for the future as well. And I'm hoping that we'll learn this time that this is something that is not something we can put off. It's essential. So, I'm sorry, you muted yourself.
Sometimes people drop in my office, and then so that's why I mute, but then I have to unmute again. So there are two questions relating to vaccines. Perhaps it's a good idea to take these as the last question. Is that okay with you?
Certainly.
I have one very last question for you, but okay. So the question is, if you cannot force your population, your people to take up this vaccine, would it be an idea to, if people come to your country, or the other way around, if you go abroad, that's the only way you can get from one country to another is that you show that you have been vaccinated. So using vaccination more as the forced preventive tool for international travel.
Yes, I think that seems like an entirely justifiable and useful measure that could be taken to encourage people without compelling them to have vaccination. And I think there may be other opportunities, such as stressing that perhaps at various levels of our educational system, that people are not able to enter school at a certain level if they haven't been vaccinated. There can be, and other institutions as well. So I think that might be an approach. I don't think compulsion is a good idea in general, but I think I would prefer to think of this as incentivizing, that if people wish to take advantage of some of the features of our society, they need to be vaccinated in order to be eligible.
Okay. Yeah, the other question was about people who don't want to vaccinate because of their religion or their beliefs. Would not that be discrimination if you block them from access to whatever?
That is an interesting ethical question. And I do agree that there is some sense in which one doesn't wish to put pressure on people to go against their religion. On the other hand, it does seem to me that no one has a right to put other people's lives at danger. And therefore, it seems to me that the larger interest of the public welfare is our highest law. And one will minimize not instituting stigma or compulsion to people, but providing, I prefer to think of that not as a penalty, but as an incentive. The example of foreign travel, I don't think that is an enormous measure of compulsion, but if you do want to travel, you can't put people in the host country at risk. I don't see why anyone should claim that right to put another people in jeopardy because they wish to travel. So that seems to me a perfect example of a way that doesn't seem to me very discriminatory.
No. Okay, thank you very much. Are there other questions from the students? Just shout or type. If not, then perhaps I can have one question to you. You already said I'm an historian, so it's difficult for me to predict the future. But what would your advice be? Because this is a class of nearly 100 global health students, majority from medical school, some from health policy and management and clinical technology. What would your advice be, looking at pandemics already and the relation between epidemics and society? What would be your advice for students to do or to look for a career perhaps in global health for the future?
Oh, well, that's a very difficult one. And I think that it's a wonderful thing to see so many people interested in careers in public health and medicine, and that is a direct contribution that you can make as a cohort of people to our protection in the future. So that I think that is encouraging people to choose that and making clear of what the rewards of such a life can be is extremely important and productive. That would be something I think that is very useful for all of us to talk about and to be aware of, in fact. So I think I would stress that as something useful and important to do, and to carry on this. And how the world reacts is not just looking at the future, it also means making resolve in the present to keep the pressure on to make these constructive changes. I think that the more people talk about preparedness and what can be done and what the alternatives are, the more likely we are as a population to be willing to move in that direction and to hold our politicians accountable for preparedness is very important. There's another dimension, I think, which is the awareness of the utility of pandemic experience of the past to enlighten us as to what can be done, what is possible. And I think this relates to something we haven't talked about, and that is mental health. I'm convinced that I was talking to a number of World Health Organization epidemiologists and a World Health Organization think tank, and they were saying that the World Health Organization is now increasingly aware of one limitation of the way in which medical faculties and public health faculties have been concentrating on the short term of crisis management rather than thinking in the long term about what public health needs to do to address the root causes of our vulnerabilities. And so I think that that's a direction, a kind of conversation that's important. And in mental health terms, I think that there is many medical journals and groups in civil society, nonprofit organizations that deal with substance abuse, suicide, and the mentally ill are saying that the combination of the coronavirus anxieties, the lockdown, and the economic consequences all put together are leading to spikes, a huge upsurge in depression and anxiety, in child abuse, substance abuse, and indeed domestic violence. And so the physical disease has in its train a mental component of mental ill health and lack of well-being that will be with us for some time as well, and that needs to be addressed more carefully than it has been, and brought more into the public discourse, as one imagines that there are now studies with regard, first of all, to healthcare providers and the degree to which people on the front lines who dealt with SARS in Hong Kong are still being under psychiatric care now and taking medication for depression and anxiety and post-traumatic stress disorder. And there is every reason to think that something similar is true with regard. Part of preparedness will certainly be to provide psychological support for responders and public health care workers in times of a pandemic emergency. But that also seems to be true among the general population now. And I think that the mental health dimension needs to be taken on board as an important part of public health as well. That would be another point that I would wish to stress.
Okay, thank you very much. I guess that's where normally when you go to medical school, in the curriculum as well as from a student perspective, to become a neurosurgeon is the near ideal picture of the future. Whereas probably we should try to have mental health, but also public health being more sexier, and then at least being more available or challenging or for the future careers of students as well.
Would I perhaps say that here perhaps the United States can be a useful warning to the world, which is to say that the United States has one of the great, should we say, is one of the great centers of therapeutic excellence. It has wonderful medical centers, wonderful research laboratories, until recently a very wonderful CDC, and it has the Johns Hopkins and centers of medical excellence, but that hasn't been sufficient to carry us through a major public health medical crisis, because what we've lacked is a public health system of excellence. And we really need to have both. And so I hope that this will help to restore this experience, the balance. We not only need neurosurgeons, we also need a greater value placed on those who provide public health if we're going to manage this challenge and those of the future.
Thank you very much for that last remark. I don't see any other questions by the students. We're busy for nearly 2 hours with our discussions. I think we should call it a day, if that's okay with you.
Well, absolutely, yes.
And I would very much like to thank you for interacting with us and sharing your thoughts and ideas and your experience, specifically your historical context of pandemics with us and with the students. I enjoyed it enormously. As I said already, I enjoyed also reading your book enormously. I've put it in the chat box a link to where students could buy the book with a 30% discount I got from your publisher, James. So I hope that everyone will rush to that website and read a book, because as I started with, I guess that from history we can learn a lot for the future, and I guess that the current COVID-19 pandemic really is something to look back into our history and to read from other pandemics and read what we did then and the similarities and the differences we experienced then and now. And hopefully that will at least make more students, or at least doctors or whoever, choose a career in public health and try to prevent future pandemics and solve this one for the near future as well.
Thank you very much. I would say I've really enjoyed being with you, and I would like to just say one word to the young people who are the students, to say that you are our future. And I hope very much that the discussion about public health and preparedness are something that you will be thinking about and carrying on that discussion, so that we educate not only ourselves, but the general public, which needs a much greater awareness of these problems and their critical importance to our future. So that would be my hope and the word I would like to leave with you, because this isn't, I don't see this as a time of, despite being a very difficult time, it's not a time of doom and despair for us all. It's a time of opportunity and resolve of how do we make this world better for the next generation that will follow us. So that seems a wonderful challenge to have. And that's what I hope that we'll all spend our time thinking about. So thank you very much. It's been a great privilege to have this chance to talk to you, and thank you for your attention.
Okay, thank you very much, Frank, and perhaps we see each other again sometime.
Wonderful.
Take care, stay healthy. You already had Corona, so you're protected for the short future at least, probably. I didn't have. We have to wait what the second and third wave will bring. But again, thank you very much.
Thank you, and stay well.
Same to you.
Goodbye.
Okay. Thank you very much.